You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is November 3rd, 2025. We will be continuing our discussion of ABAS Chapter 2, presented by Dr. Nikita Raje, an Associate Professor of Internal Medicine, Pediatrics, and is the Section Chief of Allergy and Immunology at Children's Mercy Hospital, Kansas City.
With chapter 2, cells and tissues of the immune system. This is from textbook of Abbas, and this is from the new edition, 11th edition. Few changes, just some additions to tables or figures that has changed. Overall concepts are the same. And yeah, we can get started. I'm Nikita Raje from Children's Mercy, Kansas City, UMKC. Today is November 3rd, 2025. Disclosures, nothing relevant to the talk today. Our objectives are to recognize the structure of various immune cells, understand the function of various immune cells, and then identify the differences in the structure of various lymphoid organs. We'll go through the cells and then the anatomy and functions of the lymphoid tissues, couple of pre-test questions, and we'll come back to these at the end of the talk. A drug that blocks the function of the chemokine receptor CCR7 would result in which of the following abnormalities? I'll let you read through that. Right, in 22q deletion, the thymus fails to develop. Which of the following characterizes the immunodeficiency state in this syndrome? We'll come back to these at the end of the chapter. So, talking about the cells of the immune system, this table just gives the general idea of how white cells, the cells of the immune system, what range they are in. Most of the neutrophils, so 40 to 60% are neutrophils, and then so on and so forth for the other cells. We'll talk about the neutrophils first. These are also known as PMNs or polymorphonuclear phagocytes. As we know, these are produced in the bone marrow from myeloid monocytic precursors, and they are produced under the influence of GCSF, so granulocytic CSF. Their lifespan is very short, few hours to few days, and then when they enter the tissue, they die within 1 to 2 days. They are about 12 to 15 micrometers in diameter and have that lobulated nucleus that gives them the name PMNs, and then they have these specific granules that do not stain with H&E stain, and that is the reason they are called neutrophils compared to the other cells, eosinophils or basophils, that do stain with H&E. These specific granules have lysozyme, collagenase, elastase, all these enzymes in them. Neutrophils also have another type of granules called azurophilic granules, and they include these defensins or catalycidins, which have antibacterial properties, and also have enzymes such as myeloperoxidase. So what's the function of these PMNs? Their main function is phagocytosis, and then they kill the microbes that they phagocytose. So that killing is intracellular in the phagolysosome pouch that they create. Versus sometimes the microbe is large so that they are not able to phagocytose completely, and in those circumstances these neutrophils will make sure that they extrude their nuclear contents onto that microbe and form what is known as neutrophilic extracellular traps or nets. Right. We can move on to talking about mononuclear phagocytes now. So we talked about the neutrophils, which were one type of phagocytes. The mononuclear phagocytes are produced in the bone marrow from myeloid monocytic precursors under MCSF influence. They are also about 10 to 15 micrometers in diameter, and they have this bean-shaped nucleus, and they have their cytoplasm is pretty granular. And you can see that in the figure here. The cytoplasm contains lysosomes, they have phagocytic vacuoles, and cytoskeletal filaments. So give me 1 second here. I'm just going to make sure I'm looking at the right screen. Let's see. Okay, again, can you see my screen?
Yep, we can see it.
Yes. Okay, so talking about these mononuclear phagocytes, so these circulate in the blood, and so they are formed in the bone marrow, then released in the circulation, and in circulation they live for about 1 to 7 days. From there, they can be recruited to infection site or injury site, where they differentiate into becoming what are known as macrophages, and they perform the phagocytosis and the killing. These all come from the bone marrow, as I mentioned, but most of the macrophages that are present in the tissues actually come either from the yolk sac or the liver. And these are the long-lived and self-renewable cells that can then differentiate into macrophages that live in the tissue and have different functions in different tissues. So in brain, they are called microglial cells. Lung, they are called alveolar macrophages. Kupffer cells in liver. There are myocardial macrophages in heart, dermal macrophages in skin, sinusoidal macrophages in spleen. There are macrophages in the lamina propria of the intestine, and these are all the ones that are coming from these organs rather than from the bone marrow. So again, a little bit different function and how they are, their origin starts. So if you look at the contribution of the precursors of macrophages in different tissues, you see how they are different. This is in mice, and what happens before birth versus after birth. But again, we talked about different tissues where they are coming from yolk sac or liver, and then after birth, a lot of the cells that are coming from bone marrow go up more in the blood circulation rather than these organs. So monocytes are CD11b positive. They also express MHC class 2 that helps in antigen presentation and help these APCs to activate the T cells using the marker called CD86, right? So they have these markers on them. So monocytes are defined by these markers on them. But there are different subtypes of monocytes. So classical monocytes are strongly positive for CD14 and negative for CD16 and CCR2 positive, versus non-classical monocytes are CD14 positive, strongly positive for CD16, and they have CX3CR1 chemokine receptor on their surface. There is also an intermediate subset which has markers between these two classes. So CD14 strongly positive and then CD16 positive. So what's the difference? The classical monocytes are meant for inflammation. They produce inflammatory mediators and are recruited to the sites of injury and infection. Versus the non-classical monocytes will crawl along the endothelial surfaces process called patrolling, and they contribute to tissue repair after the injury. Rather than causing inflammation, they are helping in the repair of the tissue. Those are the non-classical monocytes. So the activation of macrophages can be two different types based on what the function is for these macrophages. So classical activation is in response to the cytokines, mostly made by the T cells, and macrophages, once they respond to that activation, they become efficient killers. Whereas the alternative activation, so the other cytokines that will activate macrophages will promote tissue remodeling and repair, as we just mentioned with the non-classical macrophages. How do these macrophages make sure that they don't damage the healthy host cells? So there has to be a mechanism for these macrophages to know not to respond to cells that are the healthy host cells, right? They can work on the damaged cells or they can kill the microbes, but they shouldn't be killing the host cells. And how does that, how do these macrophages know? So there is a molecule on these macrophages called SIRP alpha, which recognizes CD47, which is present on healthy host cells, and that is the reason the macrophages don't kill them. All right, so looking at the functions of macrophages, they have multiple of these functions, the most important of that being phagocytosis and killing. So macrophages are activated by microbial products such as, say, LPS or other microbial molecules, versus they can also be activated by cytokines that come from, say, natural killer cells like interferon gamma. So once these signals interact with the receptors on the surface of the macrophages will get activated. That leads to activation of some transcription factors that will lead to the transcription of some genes and synthesis of some proteins that will help in mediating the function of these macrophages. The function through these molecules is in form of, say, giving rise to inflammation, such as through the cytokines that are released from macrophages, or phagocytosis, that is a function of phagocyte oxidase and inducible nitric oxide, right? So that helps in the phagocytosis and killing. Apart from these, there are other functions of the macrophages, such as they act as sentinel cells. So in the tissue, they are just present and they are making sure that whatever comes into the tissue is not an invader. And if it does come across the invader, it will send signs out so that they can recruit cells from outside. So that's their function as sentinel cells. They also have a function called pyroptosis, which means macrophages will get activated and go through the activation of something called inflammasome and lead to pyroptosis. Macrophages are really important in clearing the cells that have undergone apoptosis. So cells that have been damaged will undergo apoptosis. But if those dead cells continue to stay in the circulation or in the tissues, they can actually release the chemicals or enzymes that are present in them and cause damage of the tissue. So to prevent that, these macrophages are pretty much like garbage disposal that are collecting all the cells that are dead, and that process is called efferocytosis. Macrophages are one type of antigen-presenting cells. We talked about that. And then there are these macrophages that are present in subcapsular sinuses or marginal zone of the lymphoid tissues. There they bind to the larger antigens that are coming into the lymphoid tissues And instead of the macrophages typically acting as antigen presenting cells and presenting to T cells, the large antigens are handed over to the follicular dendritic cells or B cells, so that the humoral response is also activated by these macrophages. We talked about the alternative function of tissue repair through angiogenesis and fibrosis by these macrophages. And then depending on the macrophages in particular organs, such as Kupffer cells or microglial cells, they have specific functions in specific organs. All right, that is those are all the functions of the macrophages. Moving on. Talking about mast cells. So mast cells are also produced from the bone marrow. For development, they need this activation factor called stem cell factor or c-KIT ligand. And these mast cells are present mostly in the tissue and few of them are present in the blood circulation. They have this cytoplasmic membrane-bound granules that are filled with acid proteoglycans that bind to basic dyes. These granules will contain histamine and tryptase, and as we know, there are receptors for IgE on the surface of these mast cells. So when the antibodies interact with these receptors for IgE, they are going to degranulate and cause the histamine or tryptase to be released. All right, apart from the tissues, and typically in the tissues, they are close to the small blood vessels and nerves, so they are close to the nerve bundle. Basophils. So basophils are produced from bone marrow, from myeloid progenitors, and they contain granules that also bind to basic dyes. So the basophils mostly circulate in the blood. They are similar cells, so they bind the basic dyes. These circulate in the blood, versus the mast cells are mostly in the tissues. But they both make similar mediators, and they express the receptors for IgE and can degranulate. Eosinophils are produced from bone marrow, from myeloid progenitors under the influence of GM-CSF, IL-3, IL-5, IL-13 and IL-5. And then cytoplasmic granules contain basic proteins that bind to acidic dyes. These can be present in tissues as well as blood. In the tissues, they are present in the mucosal linings. Let's talk about dendritic cells. So dendritic cells come from the bone marrow, and they come from this common dendritic cell precursor and can become either a classic dendritic cells or can become plasmacytoid dendritic cells that actually come from the lymphoid progenitor, or the monocyte precursor that becomes monocyte and then becomes a monocyte-derived dendritic cell. So it can come from a variety of precursors. Versus there are some dendritic cells that are produced in the fetal liver, and the one that comes from the fetal liver becomes special dendritic cells, and they go to the skin, and they are called Langerhans cells, and they are identified by presence of what is called Burbeck's granules. And these dendritic cells from the bone marrow are produced under the influence of FLT3 ligand. The dendritic cell, as the name suggests, has these dendrites or long projections that help them look for whatever they are coming in contact with, and kind of, look for any kind of invaders that they might come across. So there are two types of dendritic cells that we typically talk about: the conventional dendritic cells and the plasmacytoid dendritic cells. So dendritic cells that present antigens to T cells, those are the conventional dendritic cells present in the tissues like skin, mucosa, parenchyma, and then once they are activated, move into the lymphatics and go to the lymphoid tissue, and they can present the antigens to these T cells. So in that sense, they are antigen presenting cells. Versus the plasmacytoid dendritic cells. These are early responders in viral infection, and they are factories that produce interferons, the type 1 interferons. So again, plasmacytoid dendritic cells, remember, those are the major producers of type 1 interferons. These figures are just showing dendritic cells derived from the bone marrow, and the electronic micrograph of dendritic cell as well, with those dendritic projections. And then here, this is showing these Langerhans cells in which these Langerhans cells will have the Burbeck's granules. In the lymph node, it is showing that there are these dendritic cells that are going to go through the lymphatics, come to the lymph nodes, and then they can present the antigens to the T cells. So here we are showing different types of dendritic cells and their surface markers as well as the transcription factors, which are different. Again, these changed from last edition to this edition, so I just added that new table here. Just something for you to glance over. The major differences are the classical dendritic cells, type 1 and type 2, plasmacytodendritic cells that make type 1 interferons, and then the Langerhans cells that are in the skin, and then the monocyte-derived dendritic cells. All right, so we talked about antigen presentation. The most important antigen presenting cell is the dendritic cells that we just talked about. But the other antigen presenting cells are macrophages and activated B cells. These three, the dendritic cells, macrophages, activated B cells, will present the antigens to CD4 cells, T cells, using class 2 MHC. But for CD8 T cells, all nucleated cells that have class 1 MHC can act as antigen presenting cells. And then that's the antigen presentation for T cells comes through those APCs. But for B cells, there are these follicular dendritic cells that are present in the lymphoid follicles. These do not come from bone marrow, right? These dendritic cells have nothing to do with the dendritic cells that we just talked about. And these follicular dendritic cells present antigens to the B cells in the follicles of the lymphoid tissue. So the reason I bring it up here again is because sometimes it's very confusing when we say dendritic cells, follicular dendritic cells, plasmacytoid dendritic cells, and they all are coming from different sources and they have different functions. Moving on to discussion about lymphocytes. So these are produced in the bone marrow from lymphoid progenitors. These cells are most prominent in the lymphoid organs. So 65% of the lymphocytes are in lymphoid organs, 15% in the mucosal associated lymphoid tissue, 10% in bone marrow, 4% in skin, and the lymphocytes that we have in the blood are just 2% of the total lymphocytes in the body. As we know, these lymphocytes are clonal, which means their specificity is different for all of these lymphocytes that are present in the body. They are what are called clonally distributed. They were diverse and they have specific antigen receptors on their surface. As we know, these are T or B cells. T cells come from bone marrow and mature in thymus, and B cells again come from bone marrow and they complete their maturation in peripheral lymphoid tissues. So B cells are different types. The typical B cells that we talk about are called follicular B cells. There are also cells called B1 B cells and marginal B cells. And then T cells, the typical T cells that we talk about are alpha beta T cells. And there are also some cells called gamma delta or natural killer T cells that are different subsets or subtypes of T cells. So the alpha beta T cells are either CD4 positive or CD8 positive. Apart from the helper T cells, there are there are other type of T cells called Tregs or regulatory T cells. We know that most of these are CD4 positive, but there are other types of Tregs other than CD4 positive. The tables here go through again the markers that are present on these cells and their percentages in different parts of the body, so blood and then lymph node and spleen. All right, so the alpha beta T cells, these are the either CD4 positive or CD8 positive. CD4 positive are negative for CD8 and the CD8 are negative for CD4. So these are single positive, but they all have alpha beta TCR on their surface. Regulatory T cells are also alpha beta. They are positive for CD25 and FOXP3. These are important markers for regulatory T cells. NK T cells have NK cell markers and T cell markers on them. So T cell marker is CD3 and NK cell marker is CD56 and CD16. So again, their TCR is alpha beta. Compared to the gamma delta T cells, which have gamma delta T cell receptor on their surface, and they are CD3 positive, but CD4 and CD8 can be variable. Another subset is called MAIT or mucosa-associated invariant T cells. These are also they also have alpha beta TCR on them, and majority of them are CD8 positive. All right, B cells, again, as I mentioned, most important B cells that we typically talk about are your follicular B cells, and they are positive for CD19 and have some other receptors on their surface or markers on their surface. The marginal zone B cells are IgM positive. They also have CD27 on them, and then the B1 B cells are, again, IgM positive, CD20 positive, and they have other markers as well. So lymphocytes, as we know, develop from the bone marrow, from the stem cell, and they mature in some part of that maturation starts in the bone marrow. For T cells ends up in the thymus, whereas for the B cells peripherally, and then these are from the thymus, the T cells are completely mature T cells called naive T cells are released in the circulation, compared to B cells where they are produced in the bone marrow, but then the immature B cells, so these have not yet completed their maturation, are released in the blood circulation. Then they recirculate from one secondary lymphoid organ to another and continue that recirculation. In that process, the immature B cells will undergo or complete their maturation in spleen and other secondary lymphoid organs, and then become naive B lymphocytes. So these mature naive B and T lymphocytes continue to recirculate in these secondary lymphoid organs till they come across any antigen that can activate them. So these naive T cells or B cells have specific type of cell markers on their surface till they get activated. And when they get activated, the markers on their surface change. Again, once the activated T or B cells differentiate into their effector cell form, they again will have different markers on their surface, and similarly when they move on to become the memory lymphocytes, they have different markers on their surface. So these are called the stages of the lymphocytes. So during that naive T cell, they are recirculating from one lymphoid organ to another. When they come across the antigen, they will recognize that antigen, and if they get the activating signals, they'll get activated. Once activated, they'll undergo proliferation, make a clone, and then differentiate into their effector cell, so plasma cells for B lymphocytes, and either a CTL or a helper T cell in T lymphocytes. And once they are become effector cells, they can perform their function of defending against the infection, and then the leftover, some cells that are left over are the memory lymphocytes that will survive longer. So here, this is just showing the difference in these stages of lymphocytes. Important thing to note here is the surface protein expression. So here we are talking about T cells. So the IL-2 receptor alpha, CD25, the same thing, right? The two names for the same marker, is high when there is activation. The naive T cells do not express CD25 on them. Once they are activated, the expression will go higher, and then when they become memory cells, again that expression of IL-2 receptor or CD25 will be lower. CD62L or L-selectin is highest in the naive T cells, and then when they get activated, L-selectin is not as expressed, and then in memory cells it can be variable. IL-7 receptor or CD127 is high in naive and memory, but low in activated or effector cells. And so on and so forth. Another one I wanted to, so CD44 is a adhesion molecule, so it's low in naive cells because it does not need to adhere, it needs to recirculate, versus it will be higher in activated effector or memory cells. CCR7 is a marker that is high in naive cells, low in activated and effector, and variable in memory cells. CD45 is present, but the isotype is different. Isoform is different for different stages. CD45RA in naive, and then it is CD45RO. So I think these markers are really important because when we do flow cytometry, the way we identify cells, whether they are naive or activated cells or effector cells or memory cells, is based on these markers. So for example, naive T cells would be identified by expression of CD62L, CCR7, and CD45RA. So CD45RA positive, CCR7 positive, CD62L positive cells that are CD3 positive, that are T cells, are your naive T cells, versus CD45RO positive cells are your memory T cells. Talking about the B lymphocytes express the B cell receptor on their surface. So the naive B cells express IgM and IgD on their surface. When they get activated and become effector cells or memory cells, they may express IgG, A, or E on their surface. So again, the surface protein expression is really important here. CXCR5 is high in naive cells, and in memory cells or activated cells, CD27 is positive. Excuse me. All right. So CXCR5 positive are naive B cells. They are IgM and IgD positive, and your memory cells may be memory cells which are IgM positive and CD27 positive, or they may have class switched and which are CD27 positive and IgGA or E positive, which means they are IgM negative. Those cells that are CD27 positive B cells that are IgM, IgD negative are your class switched memory B cells. We talked about these. These are mature lymphocytes, but have not come across that antigen, and they continue to recirculate, but they die after about 1 to 3 months of recirculation if they do not come across the antigen that they are specific for. These are small in size, 8 to 10 micrometers, and for the cell cycle, they stay in G0 stage of cell division cycle. Once they're activated, they'll move on to that cell division cycle stage G1, and they grow in size, so 10 to 12 micrometers. These lymphocytes need some motivation to stay alive. So they need these survival factors that are important. And typically, that is provided to them by self-antigens that can just about keep them alive but not make them activated. The other way to keep them alive is having cytokines around or survival factors around. For T cell, that's cytokine survival factor is provided by IL-7, and for B cells, that's provided by B cell activating factor called BAF. All right, we talked about the marker CD45RA. RA stands for restricted A, that is encoded by something called exon A. Effector lymphocytes, once activated, they grow, proliferate, differentiate into effector cells. T helper cells can express CD40 ligand. In cytotoxic T cells, they will express the cytoplasmic granules that are needed for their action. The CD40 ligand is also known as CD154. These activated and effector lymphocytes can now express the IL-2 receptor alpha, also known as CD25. So CD25 is a good marker of T cell activation. These effector lymphocytes are short-lived and not self-renewing. Talking about B cell effector cells called plasma cells, these have eccentric nucleus, and then the chromatin around the nuclear membrane is in cartwheel pattern, so has a very specific, and they are larger in size compared to B cells. They have the endoplasmic reticulum, Golgi complex in cytoplasm, and secrete antibodies, thousands of antibodies per second. These plasma cells develop in the lymphoid organs and sites of infection and migrate to bone marrow, where they live and secrete antibodies. Plasmablasts are precursors of long-lived tissue plasma cells. They are found in blood only in low numbers. These are the figures showing a lymphocyte cell and the eccentric nucleus of the plasma cells. Talking about memory lymphocytes, these have IL-7 receptor on their surface and the CD45RO. RO is where exon A is spliced out, so the O is for the spliced out RNA exon A. That's the reason it's called CD45RO, that's present on memory T cells. Memory B cells have CD27 on them. CD27 is a good marker for B cells, and they may have IgM positive or they may have GAE on their surface. As when the baby is born, they have 80 to 90, or pretty much most of the cells are naive T cells, and they do not have memory T cells. As they grow over the years, the naive T cells go down in number and the memory T cells go up in number. ILCs, innate lymphoid cells, these are bone marrow derived, and their morphology is similar to lymphocytes, and the effector function is similar to T cells, but they lack the T cell receptor on their surface. They are called innate lymphoid cells, or ILCs. They are part of the innate immune system, and they provide early defense before the adaptive immune system is activated. They recognize and eliminate stressed and damaged cells, and their types are ILC type 1, type 2, type 3, and so they also secrete some cytokines that are similar to what come out of different helper T lymphocyte subsets, and they also produce the lymphotoxin as well as TNF. All right, that's all I wanted to talk about the cells. We move on to lymphoid tissues. The lymphoid tissues, as we know, are primary or secondary. The primary, generative, or central lymphoid tissues are bone marrow and thymus, and then the peripheral lymphoid tissues or secondary lymphoid tissues include lymph nodes, mucosal associated lymphoid tissue, MALT, spleen, cutaneous immune system, and then some aggregates in other organs and connective tissue. Let's talk about these organs. Bone marrow gives rise to all the blood cells, all the immune cells. At birth, all the bones have that bone marrow that produces blood cells, but by puberty, most of the blood cells are produced in the flat bones, so sternum, vertebra, iliac bones, ribs. Not gonna talk about the blood bone marrow structure here. Hematopoiesis, I feel like this is something that you guys already know about. Sorry, give me 1 second. All right, so these cells come from the precursors, and we talked about and went through these. This figure mainly shows just the information about the growth factors, how initially it's lineage independent growth factors that are important for proliferation of these precursors, and then there are lineage specific growth factors that are important as the cells differentiate and move into that process of hematopoiesis. The cytokines that we already talked about, what's needed for each type of cell is mentioned in this table here. Talking about thymus, it has the medulla and the cortex. So here it shows the structure of thymus. The thymus is a bilobed organ in the anterior mediastinum, and each lobe has multiple lobules divided by septa. Each lobule has outer cortex and inner medulla. Cortex has dense T cells collection, and then in the medulla there are lymphocytes, but also macrophages and dendritic cells and non-lymphoid cells. Cortical epithelial cells. So these cortical epithelial cells will produce IL-7, and then medullary thymic epithelial cells are important for presenting self-antigens to the developing T cells. Also, there is a structure called Hassel's corpuscles, which are rows of epithelial cells in the medulla, which are the remnants of degenerating cells. All right, so in the thymus, the lymphocytes are in various stages of maturation. They are called thymocytes. Cortex, there are immature thymocytes, and as they move from cortex to medulla, they undergo maturation and selection, positive and negative selection, and end up being mature thymocytes or mature naive T cells that exit the thymus, where they are called recent thymic emigrants or RTEs, and they enter the blood circulation. The lymphatic system here is showing how these capillaries come together to kind of overlap the endothelial surfaces with one-way valve, right? And these are basically pumping up the lymph fluid as they collect blood from the interstitial fluid. Lymph from the interstitial fluid. That lymph flows through lymphatics due to the contraction of smooth muscles, and then these lymphatics will go from one lymph node or one secondary lymphoid tissue to another to converge into larger lymphatic vessels. They end up to form what is known as thoracic duct or right lymphatic duct, and then they pour all that lymphatic fluid into the superior vena cava, about 2 liters a day. So talking about Dr. Pandya, can I have like 5-10 minutes? I know I started really late, so I haven't finished it. So just
take as much time. Yeah, I was going to text you. Take as much time as you need. I actually shortened our board review too, so ours will take like 30 minutes. So please take all the time you need. I'll be right here whenever you're done.
Thank you. All right. All right. So the lymph nodes, these are encapsulated organs, right? They are an important secondary lymphoid organ with efferent lymphatics. So let's look at the flow of blood and lymph through this system. So here are the efferent lymphatics bringing in antigens. So say there is an injury where the dendritic cells got activated, they move through the lymphatics and bring the antigens in with them, like the information about the antigens with them, and enter the lymph node through the efferent lymphatics. These efferent lymphatics will end into a subcapsular sinus, and then that subcapsular sinus will form these medullary sinuses, and then finally collect all of that into what is known as efferent lymphatics. And the efferent lymphatic vessel will take the lymphatic flow out of the lymph node. So that's where the antigen enters the lymph node. Also, the blood circulation can bring in lymphocytes into the lymph node, and so there is arterial and venous flow to the lymph nodes. In the lymph node, there are two regions. There are these follicles, which are known as the B cell zone. So the follicles make the B cell zone, and then the paracortex. So in that cortex are the follicles, which are the B cell zone, and near the cortex or paracortex region has what is known as T cell zone. So the follicles can be primary or secondary. Typically, initially, they are primary follicles, and when there is activation of B cells, they produce something called germinal center in that follicle to make secondary follicles. So here again, it shows that B cell zone or the follicular region. The follicular region, as I said, has the B cells in them, but when there is activation of B cells, these B cells will proliferate and select the B cells with high affinity antibodies, and that gives rise to the secondary follicle. Here they will undergo affinity maturation and switch class of the antibodies, and that also helps in generation of long-lived memory B cells and plasma cells. So that's the function of these follicles. Versus, let's look at the T cell zone or the paracortex. So the paracortex, the T cell zone, is central to the follicles, right? Beyond the cortex, and it is formed by a network of something called FRCs or fibroblastic reticular cells. They form conduits called FRC conduits. So here is your reticular fibers, and this is the fibroblastic reticular cell. All right, so what do these conduits do? They contain extracellular matrix molecules or collagen fibers that again has that layer of basement membrane around them. These extend from the subcapsular sinus and then move on up to this the medullary sinus of the lymphatic vessel. So here, the T cells are the ones that are going to be attracted to in this region because the FRCs produce chemokines that help them attract T cells to this region. So that's the part of the lymph node that's called T cell zone. So talking about how these T cells end up in the T cell zones, and then the B cells end up in the B cell or follicular region or the cortical region of the lymph nodes. The reason for the movement of the cells in particular areas of the lymph node is because of particular chemokines and chemokine receptors. So the FRCs in the T cells produce CCL19 and CCL21 from them. And these chemokines will attract any cell that expresses CCR7 on them. So typically, the naive T cells express CCR7, and these naive T cells, when they enter the lymph node from the circulation, they will move towards the gradient of CCL19 and CCL21. The dendritic cells enter the lymph node through efferent lymphatics, and they also express CCR7 on them, so they are also going to move towards the T cell zone. And that's really important because the dendritic cells are bringing in the antigen, and the naive T cells are the ones that need to interact with the dendritic cells. So they both express CCR7 on them. Compared to naive B cells, these enter the lymph node through high endothelial venule, right, from the blood vessels, and these naive B cells express CXCR5 on them. The follicles have these cells called follicular dendritic cells that express CXCL13, and that chemokines attract any cell that expresses CXCR5. So the naive B cells that express CXCR5 are going to move towards the region which has CXCL13, which ends up being the B cell follicles. That's how the T cells and B cells know where to go when they enter the lymph nodes. All right, what happens to the antigens when they come to the lymph nodes? So the antigens are sorted by their molecular size. The floor of the subcapsular sinus that is just under the capsule will only allow specific molecules to pass through. So these sinuses will have macrophages which will take up the big high molecular weight antigens, and the low molecular antigens move out of the sinus and then go through the FRC conjugates. So basically, the macrophages are going to take care of the bigger antigens that cannot go to the specific regions. All right, so that was the information about lymph nodes. I have a few more slides that I want to go through, but I want to stop here because that is a lot of information. Questions about any cells or the lymphoid tissues we just talked about? All right, so we'll move on to talk about spleen. So the basic structure of all secondary lymphoid organs is pretty similar. It has a B cell zone and it has a T cell zone. And then there has to be some way of bringing in the antigen, and there has to be some way for the lymphocytes to enter that secondary lymphoid tissue so that they can interact with each other. Right? So that's the purpose of the lymph nodes or secondary lymphoid tissue, to bring the antigen and the lymphocytes so that the lymphocytes can be activated. So we talked about lymph node, keeping that as the basic foundation of that knowledge. We talk about the spleen as what the differences are. So spleen is a different system. It is a highly vascularized organ with a lot of red pulp, and then it has the white pulp which has more lymphocytes. So in the red pulp, the blood enters through the splenic artery, and then that splenic artery divides into branches and then goes through the vascular sinusoids. These sinusoids are lined by macrophages, and then those sinusoids together will end up in venules that will carry the blood into the splenic vein. On the other hand, that's the red pulp. On the other hand, the white pulp has densely packed lymphocytes, and they typically are surrounding the central arteries. So here is a central arteriole, and the lymphocytes are around those areas. And these central arterioles will then drain into marginal sinus surrounding the marginal zone. Here, the lymphocytes form two zones, T cell zone and B cell zone. So B cell zone is the follicular region. Remember, the B cells make follicles. So wherever there are B lymphocytes that are attracted, they form the structure of follicles. Whereas the T cells are close to the around the arteriole, and so it's called periarterial lymphoid sheath, or PALS, P-A-L-S, PALS. So that is the T cell zone in the spleen, and then the B cell forms those follicles, right? So that's the structure of the spleen. There is regional immune system, so skin, GI mucosa, bronchial mucosa, they can all have lymphoid tissue. That lymphoid tissue does not have that kind of a encapsulated structure that some of the other lymphoid organs have. All right, so that's about it. Couple of questions again. Drug that blocks the function of the chemokine receptor CCR7 would result in which of the following abnormalities?
A, reduced number of T cells and lymph nodes.
That is correct. So if the CCR7 is blocked, the cells wouldn't know how to get to the lymph nodes, and then in the lymph nodes going to the T cell zone. So the number of T cells in the lymph nodes would get reduced. In 22q deletion, thymus fails to develop. Which of the following characterizes the immune deficiency state in this syndrome? Couldn't hear you, Dr. Shopper. Were you saying something?
I go with C.
C?
Yeah.
Okay, yeah, that's correct. So there's deficiency of T lymphocytes because thymus is not well formed. There are midline structures that are defective in this disorder, but the immune system is affected because of the low T lymphocytes. All right. Questions?